We tell communities what to do, and sometimes we lack empathy for the fact that when we're saying don't touch a loved one who's sick to protect yourself, what parent wouldn't touch their child who was sick and crying for help?
There are no known treatments for it, and there is no vaccine.
If you're in a community that has a terrible history of colonialism, would you trust a foreign organisation coming in, wanting to inject you with something that's experimental? The US pulled out of the WHO, pulled funding. So all of these things really undermine the collaboration and the resources necessary to develop things like a vaccine.
Do you think Trump's cuts could be directly responsible for more deaths? Hello and welcome to the Fourcast. The World Health Organization has declared the Ebola outbreak in the Democratic Republic of Congo an international emergency, with around 350 suspected cases and 91 deaths. Uganda is also reporting cases, including in the capital, Kampala. It's a strain of the disease for which there are no approved drugs or vaccines, and it comes just as Western nations have slashed international aid funding, prompting fears of an outbreak on the scale of the 2014 Sierra Leone epidemic, which killed over 11,000 people. Joining me is our health and social care editor, Victoria MacDonald, and from Cape Town, Dr. Oliver Johnson, who led the Ebola isolation unit in Sierra Leone's main hospital in 2014, after the lead doctor died from the virus. Victoria, what has happened and why are the WHO calling this an emergency?
It seems to have spread faster and without people realising that it was happening. And the WHO took the unusual step, and it is unusual, of the Director General deciding that this was a public health emergency of international concern without actually waiting for a committee approval. And it is simply because of the region it's in the Democratic Republic of Congo. It's a harder to get to region. There is conflict there. It's very, very poor. The issue for the WHO is that it took a little while for this outbreak to be confirmed. So the first case was on the 24th of April. He died 3 days later. But they didn't learn about the other cases really until about the 5th of May, and that was through social media. So there was a bit of a delay, but they have reacted very quickly since then. And of course, it is transmissible, not as transmissible as COVID, but it is transmissible. And it has quite a high fatality rate. And now we can see, as you mentioned, that it's spreading across borders, and we see the 2 cases in Uganda, and that is precisely what you do not want to happen with Ebola.
Oliver, you have seen this disease close up, and I think the Ebola word is one that strikes fear right around the world. Can you tell me, what is it? What is it like to encounter? Is it the case that everybody who gets it dies? How fatal is it?
So Ebola is a disease, and there's a number of strains. This is a slightly unusual strain that hasn't been the common strain in other recent outbreaks. And that's why the vaccines we've developed in recent years and some of the other treatments aren't effective, as far as we know, for this strain. But it's generally spread from patients who might have diarrhea and vomiting. And if you come into contact with that and you were to not wash your hands, you yourself can become sick. So it's quite transmissible, but it's not airborne. But I think what makes people so afraid is the very high fatality rate. So somewhere between 30 to 50% of people might get sick. And it's often caregivers who become unwell because they have so much contact with people who are sick. So that might be mothers or family members, but it's also health workers. And so it's particularly frightening for health workers in facilities who, in doing their jobs and in trying to care for members of their community, can become exposed.
And what happened in 2014 to make that outbreak affect so many people? How did it spread so far and affect so many people? So what is it they need to avoid with this outbreak?
An outbreak response is always a race. It's a race between the outbreak and the response. And as a response, you need to get ahead of the spread of transmission. And unfortunately, this outbreak has a big head start. So there are a large number of cases. They've already spread to different cities. One of the challenges in 2014 was that the outbreak happened across borders, started right on the border between Guinea, Sierra Leone and Liberia. And of course, people are moving quite freely across these borders, as they are between Uganda, South Sudan, and the DRC. But health officials and health workers are not moving so freely. So that's a challenge. In both cases, these are outbreaks that are taking place in quite unstable regions with limited health services and quite high levels of mistrust in government responses and sometimes in health systems. So all of those things meant that the transmission was happening quite quickly, and we were too punitive in treating communities like they were the problem and treating communities like they were a threat, rather than recognizing that these are families, these are mothers caring for their children, and what they needed was empathy, what they needed was support. And I think that is what's so important as we go forwards, is putting communities at the center of this and truly caring for every single person that's affected, rather than treating like them as a threat to be contained.
I mean, the big fear, Victoria, is going to be, as Oliver suggests, that this is already much bigger than we know. I mean, when they talk about 91 deaths, how certain are they? I mean, are they confirmed to be Ebola, or are these sort of people with symptoms that have died?
Yeah, they're very cautious about putting numbers on it without testing. But of course, testing is limited when you're in a region like this. But they're pretty certain that that's the number of deaths. What they are also pretty certain of is it doesn't represent the true figure at all. And that is one of the big issues here. So this is a strain called Bundibugyo, and it is one of 4 strains of Ebola that impact humans. It is a lesser known strain, and as Oliver said, there are no known treatments for it, and there is no vaccine. And I've been thinking a lot about when I was in Liberia in 2021, and there was an outbreak in Guinea on the border there, and so many lessons have been learned from the outbreak he was referring to in Liberia and Sierra Leone and Guinea. So they were able to start vaccinating. They do what's called circle vaccination. So they start vaccinating the surrounding populations, and they go out to the borders. And it's really helped contain that form of the virus. They can't do this in this case because there is no vaccine. And that, again, limits how they can treat people, how they can get the fatality rates down. But some of those lessons from the very big outbreaks will be crucial now. And the biggest one, as Oliver said, is trust, is getting to those areas where they have a terrible habit of attacking medical treatment centres, for instance, and healthcare workers are particularly at risk, but they are flying, and the WHO has already got 3 treatment centres on the ground. MSF is on its way there. So they're getting the necessary facilities onto the ground after a certain amount of delay, and then they will have to do just what they can to try and help those poor people who develop this.
Oliver, why isn't there a vaccine?
So one of the challenges with an outbreak like this is they happen unexpectedly for a relatively small number of patients, and then they stop. And in that period of time, to develop a vaccine, you need to do a whole clinical trial. So you need to have the clinical trial plans in place. You need to have the stocks in place. You need to have government permission to do a trial. You can test certain things in the lab, but the reality is that to do a clinical trial, you need to do it on real patients who have the disease. And so during the quite prolonged West Africa outbreak, which went on for over a year, there was time to do a clinical trial. And as a result of that experience, we've had a vaccine we can deploy. So one of the big challenges is simply that it's very hard in an urgent situation in a remote region to do a clinical trial. And what we don't yet know, and I know that the WHO and others are looking at this, is do some pharmaceutical companies or governments have potential vaccines that could be trialed for this? And how quickly could we put those trials out there? But of course, again, trust is critical. If you're in a community that has a terrible history of colonialism, a terrible history of exploitation, would you trust a foreign organization coming in wanting to inject you with something that's experimental? So, it's very, very important that we do clinical trials. It's very important that we do them in a way that has trusted voices at the centers, which might be faith leaders, business leaders. It's not necessarily government officials that people will trust. But the reality is that over the last few years, we've seen massive cuts to global health, massive cuts to research and development, to frontline health services. Britain has been responsible for the largest cuts. I was in Sierra Leone last week, seeing the impact of these British government cuts to aid. But what we've also seen is less and less collaboration. So the United States Center for Disease Control is no longer collaborating with the World Health Organization the way it used to. Of course, the US pulled out of the WHO, pulled funding. So all of these things really undermine the collaboration and the resources necessary to develop things like a vaccine that would protect all of us.
I mean, could you just develop that a little bit? I mean, in terms of the impact of the US leaving WHO and the cuts from USAID and the British government as well. I mean, what is the actual impact on the ground, and how does it affect an outbreak of Ebola specifically?
So the reality is that when you have an outbreak, your most important assets are the ones that already exist on the ground. They are the frontline health workers who may or may not be at work in the clinic, depending if they've been paid and if they've been trained. You know, it is the everyday supplies of gloves and aprons and soap and running water. It's the four-wheel drive vehicles to get out to those regions. So there is a need for an immediate injection of resource and some specialist equipment. But that's only really 5 or 10%. Most of what you need is hopefully present. But what these cuts have done is they've hollowed out non-profit organizations. They've caused governments to make difficult cuts. I should also add that the conflict in Iran has caused an increase in fuel prices. It's caused an increase in inflation and poverty. This has pushed communities, this has pushed governments more and more to breaking point over the last 6 months and recent months. So there are a lot of factors that have undermined health systems generally, have undermined the presence and the trust in international community members. So one level is what's happening on the ground. The other level is more at a high level. It's to do with international laboratories. It's to do with the ability to quickly mobilize international assets. When we had the West Africa outbreak, when President Obama was in office, he would be on the phone to world leaders in South Korea and in Europe, lobbying them to deploy labs and supplies. There was a real sense of global solidarity, of which the United States and Britain were at the center of, in trying to mobilize all the assets available worldwide and get them into the field as quickly as possible. And there was moral leadership. So you saw the then US president hug a recovered nurse who had Ebola in the US, invite her to the Oval Office to hug her on camera. You saw the president speak directly to the people of West Africa to encourage them to get tested and to get treatment. And so there is certain financial resources, there's certain investments, but there's also the sort of spirit of collaboration and the effort of coordination. And we live in a different time now that makes that much less likely, and it will make this much more vulnerable to an outbreak like this getting out of control.
So do you think Trump's cuts could be directly responsible for more deaths?
You know, I think that these situations are complex, but there's no doubt that the kind of cuts we've seen from the US, but I would add the kind of cuts we've seen from the British government, and Britain is spending less money now on aid than it has since, I think, when Margaret Thatcher was in office. We've seen huge cuts. In a country like Sierra Leone, the British government's almost completely pulling out of health funding. And so it's not just the US, but a range of countries that have made very significant reductions to the investments they're making for health. Across the board, from what exists internationally to what's available on the ground, it makes us far more vulnerable to outbreaks like this. And it will be far more expensive now to contain them. Because if you can get in there early with the resources that exist, if you can limit the number of cases that are affected, you know, it's a much less expensive operation to try and contain the outbreak. And of course, it saves a lot of lives and reduces the secondary impacts. You know, one thing that's worth mentioning is the people who are dying as a result of this, they're not just dying because of Ebola. Because of this, health centers will be closing down. Women who are in labor won't be able to have a supported delivery. People with HIV won't be able to go and get their medicines. People with malaria won't be able to go to an emergency department. And so the ripple effects of this are going to be huge financially and in terms, more importantly, of human impact. So no doubt the cuts from the US and the UK are making this a lot worse. And I hope this is a moment of reflection and realization that these investments in global health are critical.
Oliver, the World Health Assembly is open today, and the Director General has said, you know, there were cuts at the World Health Organization. So it's not just America or the UK. How do you think the WHO has dealt with this so far?
The first thing to say is I think the WHO has responded much more quickly. I think that obviously there was a delay in realizing that there was this outbreak in this remote region. And because it was an unusual strain, it was difficult to get the laboratory samples to a particularly specialist lab to identify what it was. I wouldn't lay that delay at wouldn't blame the WHO for that at all. I think once the WHO found out about this, they have responded very quickly in declaring this a public health emergency. They've responded very quickly in trying to galvanize the international community to mobilize a response. But of course, they have a limited capacity. They only have so many specialists they can deploy, so much resource at hand that they can put into the field. And so with the best will and with some really excellent experts in the WHO working on this, they simply have diminished capacity and resources right now as a result of these cuts in their ability to respond and mobilize. And what I hope is that in the short term, they will be resourced by international donors and governments very rapidly so that they have what they need to put resources on the front lines right away. But also that we take this moment to realize that we need a strong World Health Organization for us all to be safe. And short-term cuts are short-sighted, and ultimately they don't pay off. They put us at greater risk.
I mean, you mentioned, the lessons that have been learned since 2014 in terms of the way you treat affected communities. Can you take us back a little bit and give us a sense of what this is actually like on the ground when something like this happens? And how people must be absolutely terrified and in grief because people around them are dying. And all we really get a sense of when we're watching it on television is Western aid workers in, what look like hazmat suits going in and out of isolated villages. I mean, give us a sense of what it was actually like.
Certainly surreal. I mean, this has escalated far more quickly, I would say, than the West Africa outbreak. It took several months to get to the level of international concern and interest in Sierra Leone, and it's just taken days in this case. But there's certainly a surreal experience where you're living in an extraordinary moment where everything has changed all of a sudden. Everything in daily life, your whole reality now for everyone revolves around this outbreak, keeping yourself safe, your loved ones safe. That said, people don't have the luxury not to work. They're living hand to mouth to feed themselves and their families every day. And so people still have to go about their everyday business. They can't just isolate at home for a few months, living off their savings, ordering things online to be delivered to their doors. They have no choice but to go to work, but to go to local markets. And so people are trying to be safe, but they have no choice but to be out into these dangerous situations. And there's a swirl of different conflicting sources of information that are changing constantly. So everyone is constantly sharing WhatsApps and constantly sharing news snippets. Some of it's accurate, some of it's out of date, some of it is frankly misinformation. And that adds to a really heightened sense of paranoia and uncertainty. And this is where people look to community leaders to step up and to be a clear voice of direction and reassurance, and why supporting those community leaders in this moment is going to be critical, and listening to them. I think too often in a response, we tell communities what to do, and sometimes we lack empathy for the fact that when we're saying don't touch a loved one who's sick to protect yourself, what parent wouldn't touch their child who was sick and crying for help? Of course, as a parent, as someone who loves their child, you're going to do that. And so I think what we've got to avoid is lacking empathy in all of this. We've got to remember how scared people are. And we owe it to those communities to not only think with empathy, but to deploy all the resources we can to support them in this moment.
I mean, the trouble, Victoria, is going to be that this is a totally different part of the continent. So there's not going to be any institutional memory in DRC because this is not West Africa. And DRC itself is in a terrible situation and is still effectively at war, despite the supposed peace agreement that Trump brokered a few months ago.
Well, in fact, DRC has had several outbreaks of Ebola. So actually there is some institutional memory there, and they have managed to contain it very well in the past. I think it's specifically where it is this time, which is a more remote region. And, you know, a region which, as I said, is terribly poor. You have a lot of, for instance, illegal gold mines. So you don't actually even know who the people are who are there. And they're not going to stop working, as Oliver said, just because they're worried about a disease that might come their way. But the DRC does technically know how to deal with this. But again, this is a rarer form of Ebola, and as we said, there is no vaccine and no treatment, and that's going to make it harder for them. But there are things that they can put in place, like the ability to isolate a person, about using PPE if they've got it, of course, about all the, and I agree very much on the cultural issues, but, you know, understanding that people might want to touch these bodies, but trying to explain to them very sensitively why it is really important not to get the fluids, and the fluids last even after death for a while, so not to get those fluids on themselves, to practice proper hygiene. Even in the Sierra Leone outbreak, you know, they had to change the way they were doing funerals, and it took them a little while to work out that they had to reach an agreement with the locals about how to do those funerals and how to do it as culturally sensitively as possible, and yet protect people. And they actually changed the way that messaging worked. So they know this in DRC. It's just a matter of getting, as we said right at the beginning, getting that trust and getting the message there, along with all the equipment, along with the gloves, the aprons, the masks, everything else that will be needed.
Oliver, you were nodding about the question of funerals. I mean, is it about stopping people from touching the bodies because they wash the bodies?
So the starting point is to understand how community members perceive the situation. And so I think it's important not to come in assuming that a funeral in the DRC means the same thing to a community as it might in London or Washington or Beijing. And in many communities, a burial is more than just a sign of respect to the dead. It's actually critical for someone's soul or spirit to reach the afterlife. And to not provide them with a proper burial is to trap them potentially in the present. And so for many people, the risk of getting sick is not as great as the risk of not burying a loved one in a proper way. And so having respect for how those beliefs shape behavior means you can start to have a conversation about how can we work together as in partnership so that we can have a dignified burial that meets the spiritual requirements of this community in a way that's also safe. And in Sierra Leone, we went in too early on and ignored local customs and practices that were profoundly spiritually important to people. And all we did is we drove them underground. We drove people away from the response. We caused burials to happen in secret at night. We caused violence against health workers for separating people from the bodies of their loved ones. And what we learned over time is that burial practices are not inflexible. If you work together as a partnership, you can explore ways that are both safe and that meet important spiritual customs. And so I think, that's something that the respondents in the DRC will know. Uganda, the DRC has a lot of experience with Ebola at the national level, but it's really important that from the beginning, we respect and appreciate those customs. And instead of a response being done to people, this has got to be a response that's done with people in partnership. One anthropologist said, epidemiologists need to think like villagers need to think like epidemiologists, and it's only when the two come together that the response will really be effective.
And who needs to take leadership now in terms of organising the international response and also any work that can go on towards finding a vaccine? Is it clear where the responsibility lies?
Well, I think the challenge is that the World Health Organization is both in terms of its international mandate, but also just in terms of its skills, its expertise, its capacity. It really is the natural organization to lead this, and it is leading it. But of course, the world's largest economy and one of the most important supporters of global health, the United States, has pulled out of the WHO, has been attacking the WHO, has been refusing to collaborate. So this is unprecedented. You know, there was some hostility during COVID between the US and the WHO, but this is a different kind of disengagement. So I think the challenge will be that we need the WHO to lead, and they're trying to lead, but other countries, other donors need to support them. And I think it'll be interesting to see either how does the US engage in a way that is supportive? And of course, there are other organizations like the Africa CDC that the US governments work with that can play an important role. They can also directly support the Congolese and Ugandan governments. But also, will other governments step up to support the WHO with the expertise, the funding that they're going to need?
I mean, you wonder whether the Americans will end up working quite closely with the WHO on this, because there are reports of Americans being exposed potentially, and American experts already potentially traveling to DRC.
Yes, I mean, there is the government response on the one hand, and then there are the public health experts in America who have incredible expertise, who will want to be involved, who will want to provide that. I think it will be just a matter of how they do. There's some confusing messaging coming out of the CDC at the moment, which doesn't help. But I'm reasonably optimistic that there will be people standing up from America. And yes, there are some reports that there are some Americans on the ground who may have been exposed. That hasn't been confirmed yet. And in that case, you know, the American government and the CDC will have to get involved, whether they like it or not.
And just on the vaccine, I mean, where does the responsibility lie? Is anybody working on it now, for example?
Well, I did just read something about how, in fact, somebody from the African CDC saying that they think it could be in a couple of weeks there might be some treatments or there might be some trial vaccines. Now, I don't know whether he was being overly optimistic on this, but there will be people having worked on this. It's just that the difficulty of as Oliver said, of developing a vaccine for something that doesn't happen that often and happens in these remote places. Or there is a suggestion that there might be some vaccines already in use that might have some effect, some sort of protective effect, but they won't know. They've just got to go there and try it.
Oliver, can I just ask you finally, I mean, what would you say about this whole question of international responsibility? I mean, over the years of Ebola that we have seen, thus far, it has not been comparable to something like COVID. It's, you know, we are now used to hearing about Ebola outbreaks that essentially stay localized, you know, with a few exceptions of people who have traveled. And therefore, we don't need to worry about it too much in Western Europe and in America. What would you say to governments and people in power about why they should be engaged with this one?
So I think, you know, one obvious issue is that this is going to profoundly affect communities. And I think we have a global responsibility of solidarity to care for and protect people in outbreaks. And I think most people around the world really feel that. You know, humanity has a long history from plagues in the 14th century onwards of you know, devastating outbreaks. And I think people care and they want to support each other. So that's the first reason. I think it's true that this is unlikely. Ebola is unlikely to cause a big outbreak in London or Washington, D.C., but only because we'll spend a lot of money on screening people at airports and making sure good surveillance is in place. And so it'll be an expensive investment. And the longer the outbreak goes on, the more sort of protective measures we would need to put in place to prevent spread, the more risk that the virus could mutate as COVID mutated, you know, over time to become more deadly that could affect us. So the longer this goes on, the more costly and the more challenging this will be, the more the economic implications will be potentially across lower and middle income countries. But the other reason is, of course, I think we owe a deep responsibility of global solidarity to these communities. If we stop for a minute to imagine how terrifying it must be for frontline nurses and health workers who are faced with this, who are bravely going to work, worrying that they could bring this back to their families. If we think about parents fearful for their child who has a fever, you know, I think if we stop and have that empathy, it should really galvanize us. There's a lot we can do. There's a lot as an international community. We're talking about, in global terms, tiny, tiny amounts of investment compared to the other things we spend money on to have a transformational effect on these communities. And I think it's a way that we can all pull together.
Dr. Oliver Johnson, thank you very much indeed for joining us. Victoria, thank you. That's the Fourcast. Until next time, bye-bye.